You've talked about severe errors. I wonder, could you give us a couple of examples of the type of thing that you found?
What classified them as severe, Christine, was when we presented them to a peer review panel. So a blinded peer review panel graded the errors according to their severity, what they thought and their expert opinion. And the peer review panel did not know if that error came from a doctor or a pharmacist. So they were blinded to who prescribed the error. So an example of one or two of the errors that were deemed as severe was that a patient was prescribed weekly paclitaxel while she was awaiting her pathology results. Her results came back as HER2 positive breast cancer, and HER2 treatment was not added to her regimen. So this lady should have also been prescribed trastuzumab and pertuzumab, as it was indicated in her situation, and it was not prescribed. So that compromises her success of therapy and treating her breast cancer. Another example then was we had a patient prescribed a regimen which we use for pancreatic cancer, but the patient actually had colon cancer, so totally different regimen was prescribed for that patient. Another error that was classified as severe as well was a patient was prescribed carboplatin 810 milligram, but based on their renal function, the dose should have been 600 milligram. So this is a 35% overdose for that patient. So they're just three examples of severe errors that we came across in the study.
That really puts it into perspective. You also reported severity scores of errors and the probability of adverse drug events. Aren't these the same thing in essence?
I had thought the very same thing myself until I'd started this study. So they are quite similar, but the distinction between the two is one is essential for getting costings for a study to assign a cost to the errors. So the probability score is that the probability that if this error had reached the patient, what is the probability it would have caused an adverse drug reaction? And then the second one was severity, was if the error reached the patient, how severe was it?
That clarifies the point. Thank you. You also did an economic analysis. Can you tell us about that?
I think it's of utmost importance, like when we do these studies, that like it's all about patient safety and patient concern, and they're a priority. But when we engage like stakeholders, like government bodies and agencies, like they come down to numbers, and the numbers is where the crunch is. So unless we can prove that we're going to be more efficient and we're going to save money for the economy, like, you know, that's where really the change will come about. So if we can be cost effective and safer prescribers, that's where change will approach. So our economic evaluation was made up of two parts. So we did labour costings and we did adverse drug event costings. So for the labour costs, we calculated the time it took to correct any error and re-prescribe it. Because when a prescribing error is made, it adds to the workload of both the doctor and the pharmacist. The pharmacist must start correcting the prescription. They realise there's an error. They must phone up the doctor, communicate it to them. The doctor then in turn must re-prescribe this prescription. It's sent back to the pharmacist. They recheck it. So this is an extra few steps in the cycle. So all labour costs associated with that error were calculated for the labour part. We also calculated then the rate per hour. So in our hospital, only senior doctors are allowed to prescribe. So you have to be a registrar or an SPR or consultant to prescribe. So we did an hourly costings as well. So rate per hour. So pharmacists and doctors alike had similar prescribing times. So approximately 4 minutes per prescription is what they both averaged out at. We captured then prescribing or infusion times as well. So the doctors prescribed an additional 835 nursing minutes compared to 30 minutes for pharmacists. So like, to put this into context, a doctor or a pharmacist could have prescribed pembrolizumab over an hour when you can actually give it over 30 minutes. So this 30 minutes of additional nursing time comes with an extra cost for the nurse to pay for her labour costs. So these prolonged infusion times contribute to prolonged patient stays, reduce the capacity of our day wards. It's the economic burden then of nursing time and associated overhead costs. But conversely then, prescribing administration times below the recommended minimum infusion times jeopardizes patient safety.
And I think you also looked at adverse event costs. Could you talk to us a little about that?
So to establish if like the implementation of a pharmacist prescribing service would be beneficial in terms of cost avoidance to the hospital, we undertook a cost analysis. And this was based on a study by Gallagher et al. And we generated these figures based on the principle that a pharmacist did not catch the errors. So the screening pharmacist, that all errors reach the patient essentially. So the adverse drug event cost and avoidance was calculated using Nesbitt et al. Based on the Gallagher method, which I just mentioned. And we adjusted then these figures for inflation as well. So in terms of cost avoidance to the hospital, a yearly net cost benefit of over 1.2 million and a cost benefit ratio of nearly €42 was calculated based on the provision of a pharmacist chemotherapy prescribing service.
So correcting prescribing errors looks like a very costly activity. Why do these errors occur?
Christine, I think it's important to address in our conversation that like no doctor sets out, or pharmacist alike, like sets out to prescribe errors. They're all unintentional. It's human nature. But as a hospital group and at a management level, we need to have systems in place to eradicate and minimize patient harm. We know that medication errors cause a significant amount of injury and preventable harm in healthcare systems around the world. And like the World Health Organization have reported, like the cost of medication errors is nearly over 42 billion annually. So I think, and along with the research as well, that time constraints, like overburdened healthcare systems, polypharmacy, complex patient groups, with inexperienced doctors, makes prescribing kind of an error-prone processing. And then we also have within the chemotherapy realm then as well, it represents a substantial risk because we've higher patient vulnerability, we've complex treatment regimens, and we've narrow therapeutic index of drugs. And we also have the wide administration of systemic drugs as well. So like these time constraints, treatment complexity, and it makes the prescribing chemotherapy an error-prone process.
Of course, in this study, the doctors were prescribing routinely, whereas for the pharmacists, it was essentially a hypothetical exercise. So the doctors were under what you might call the normal work pressures.
The doctor, they weren't aware that the study was taking place as well, so they were blinded to it. Now, the normal practice is that their prescriptions are screened by a pharmacist. So a pharmacist will always check their work, regardless of pharmacist prescribing. So the doctors are always conscious that we as pharmacists check their work. But they just didn't realize the study was taking place, that we'd be comparing their prescriptions to another set of prescriptions. And like in our hospital, like the guidelines are that only senior doctors can prescribe. So like these aren't even intern or junior doctors or SHOs, like these are well-versed, experienced doctors.
And finally, what conclusions were you able to draw from this study?
The study has shown that pharmacist prescribing and better use of our expert skill set results in significantly fewer chemotherapy prescribing errors than doctors. It minimises workload for healthcare professionals. We reduce the risk of adverse drug reactions and patient harm, and it has the potential for substantial cost savings for our hospitals. Most importantly, it improves patient safety, and therefore this is ultimately why this initiative, it should be considered for implementation in cancer care services on a much wider scale.
Shannon Nally, thank you very much for describing this very interesting project to us. We look forward to hearing how the results are used in future. For more information about Shannon Nally's work and the ongoing research at University College Cork, please visit our website using the link in the description. And be sure to subscribe for more news, videos and journals. For updates straight to your inbox, please follow the links below. And thanks for watching.